Profit.
Good afternoon. We have a great group to discuss healthcare delivery in the 21st century. We have representatives from government, academia, venture capital, and industry. Medicine in the 21st century will be radically different than it was in the 20th century. We may not know what it will look like, but there is certainty that change will occur. There will be a converging of technology. The world will be different. The science will be different. The payers will be different. It's somewhat Darwinian. Those who prepare for the future will survive, and those who are blinded by preconceptions will fail to adapt to these new circumstances. Frequently, inertia, both intellectual and emotional, tend to trap people into antiquated ways of thinking, even though circumstances radically change. Doing what others do, and even doing it better, is not going to get us there. We will have to innovate, and our distinguished panel today will discuss many of those ways that innovation will occur. First, we're going to have everyone introduce themselves. Sue, why don't you start?
Sure. Good afternoon. It's great to be here. My name is Sue Siegel, and I'm CEO of GE Ventures and Healthy Imagination.
Annie Lamont, Managing Partner of Oak Investment Partners, in charge of the Healthcare and FinTech Group.
My name is Larry Jameson. I'm a doctor and a scientist. I oversee the healthcare system and the medical school at the University of Pennsylvania.
Jared Bernstein. I'm an economist and a senior fellow at the Center on Budget and Policy Priorities in Washington, D.C.
Peter Bach. I'm a physician, and I run the Health Policy Center at Memorial Sloan Kettering Cancer Center.
Okay, let's get started. Annie, what are VCs investing in that will transform healthcare? And before you start, with transformation, does that mean better healthcare for those that can afford it? Or will people have to choose between doing what they know is right for their long-term health and putting food on the table for their families?
Why don't we deal with the latter question last week? Let's start with what we're investing in. So slide 26, maybe put up. We can talk about what the VC world's investing in and whether it's really transformative or not. Some of this is and some of this isn't. So there was $2 billion in 2013. I think slide 24. $2 billion last year invested in digital health. So not biotech, not life sciences, not specifically devices, but digital health. And these were in these 6 areas principally. Electronic health records, big data, digital medical devices, wearables, population health management, and consumer engagement. And what's interesting about this is I think 4 of these 6 areas are consumer-oriented. And you might ask, do we have healthcare consumers yet? Are consumers paying for healthcare? Can you put up slide 30? Okay, that's not the slide. So,
Although it's
what
true.
I'm looking for is video. I'm looking for the video. Can you run that? All right, well, we'll keep talking until they find it. So I think the real question is, who's paying in healthcare? Mm-hmm. And when you think about who the real customers are, they're payers, providers, pharma, employers, but they aren't consumers yet. And so when we think about healthcare, we think about investing in, our sort of motto is, we make money by saving money. And I think that's really where we have to be in the next, really the next decade or two in healthcare, because we've got $800 billion of waste in the system. This isn't, to your question, Dick, this isn't a matter of depriving people. Okay, now we've got our video.
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Stop. I don't need both, just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
So that's the world we all live in, right? I mean, it's kind of amazing. You don't even think about understanding prices. So when we think about investing, it's actually providing solutions to consumers, but through employers or some other means, somebody who's actually going to pay for the solution. And that, I think, is an example of there are really two parts to consumerism, I think, in healthcare right now. First, you actually have healthcare.org, public exchanges, is actually consumerism. You are actually, for the first time, learning how to intelligently buy healthcare. Benefit Focus, one of our companies, is the largest exchange. They actually have put 22 million people through employers and payers on healthcare exchanges, private exchanges, effectively this January. And that's that's real consumerism, because you're actually you're given essentially defined contribution amount of money, and you're buying your insurance. So that I would call the first act. The second act of being a consumer is understanding what does something cost you in the healthcare system, and what are you getting for it? What is the quality? What's the not just quality, but location. I mean, there are lots of considerations when looking for value in healthcare, and we don't have it yet. We invested in a company called Castlight, which went public last quarter, and what they're doing is, through employers, a B2B2C model, is providing a website that effectively tells you where you are in your deductible. If you are at a soccer field on a Saturday and your child has broken their leg, or you think they might have, you look at a mobile app and you'd say, gosh, I could go 2 miles to the local emergency room and it would cost $3,000, of which I'm going to pay $1,000. Or I could go to this clinic that's a half a mile away, pay $200, and they have an X-ray equipment, and they're rated, have a 4-star rating. So, I mean, that's the healthcare world that we are beginning to live in, and I think is going to absolutely transform how we think about it.
So is that healthcare for the more sophisticated consumer? If you're an unsophisticated consumer and you have an issue and your deductible is so high, you have to choose whether to follow your doctor's instructions or not. And you might not be able to afford that deductible. So I guess I have 2 questions for you. One, if you have some symptom and you're asked to get an MRI, and you're not sophisticated enough to know if you need it or not, and you'd rather spend the money doing something else, is that really healthcare, and is healthcare a right or a privilege?
You get all the easy questions.
Yeah, wow. So, I mean, do I think it's a right or privilege? I think it's a combination. I think it's a right, and I also think there are different gradations. But I also think it has to do, it's not just about consumerism, it's also how we organize the healthcare system is the most important thing we can do. It's aligning incentives. And if you look at, Kaiser, Intermountain, Geisinger, I mean, the most successful models from a quality perspective are also the lowest cost models in America. And so it is really about integrated care, tightly integrating care, coordination of care. It's not about, this particular surgeon is rated, a 5-star surgeon. It's really about the entire process of healthcare. And if you go back to if you think about the 80s, I mean, the one thing that actually worked, I think having some sort of gatekeeper and a system which cares about you as an individual and is following you through the system is ultimately going to be the only way, because it is obviously it's a consumable that we can only have so much information on, and you really need an educated system which is they're aligned and incented to keep you healthy. I mean, that is really the only way that we're going to be able to treat people, care for people at the right cost.
Peter, as both a doctor and the spouse of a patient, you have a unique vantage point. You've been an outspoken critic of high drug prices. And I think you mentioned that the only factor that dictates a company's prices is corporate chutzpah. Can you discuss this?
Sure. Well, thanks for asking. And I'll take a stance on this also. I don't think healthcare is a right. Unfortunately, it is currently a privilege, and that is partially a product of high unit prices and high coinsurance for a lot of patients. So even if we think it's should be something that as a wealthy society we provide to all people, we don't currently. So if we can, oh, yikes. Sorry, we'll get a slide up here. 27, please. Great. So I have actually been focused on drug prices, and a few years ago I wrote a piece that this is an updated graph from, arguing essentially that this system was rigged. And I didn't mean that in a contentious way, just that we had a regulatory structure that just essentially allowed new products coming on the market to price based really on what they felt was safe, as opposed to sort of garnering headlines in USA Today for critique. And what's shown on this graph, this is adjusted in constant dollars from the beginning of the Medicare program on the x-axis, is every new drug for cancer introduced and approved by the FDA. Shown on the y-axis, and every year I have to rescale this. Of course, I have to extend the x-axis. I have to extend the y-axis much more. But shown is the monthly price of each drug. And what you can see here is that the median cost of drugs is rising very rapidly, much faster than the rate of medical inflation overall. And we're heading to an unsustainable system. Things that can't go on forever won't. But the question is really, what are we going to do that's going to transform this? And I would take the view, and I don't think anyone will oppose me on this, that the incremental cost rises here exceed the incremental value rises. In other words, we're at diminishing returns, or we may be on the flat part of the curve, no matter how you measure value, no matter what the extent of it is. And there's no drug here for hepatitis C on this graph, but we've recently seen the introduction of a drug that if you do the back of the envelope math for hep C, and you go to the population that's affected, and you calculate based on the sticker price, which isn't totally appropriate, but if you did, we're at about $250 billion for that drug if we get it to everybody.
And that's just in the United States?
That's just in the US. The good news is our system is so bad at delivering care that probably only a small fraction of patients will get those drugs. That was meant to be snide, by the way. But so we won't spend that much, but this is sort of an example where we're going into, this is pricing into a market that has no lens around value. And so prices are just pulled out of thin air, very high, really to the point that they filter into premiums in patients' bank accounts. Most patients with cancer, for example, are in the Medicare program. Most of them are on fixed incomes. The piece we had where we talked about another drug, Zaltrap, a few years ago, we made the point that a month, the coinsurance in a month of that therapy was equal to the median monthly income of the median beneficiary in Medicare. Meaning it was about $2,200 out of pocket for the patient to get the drug. That was the take-home pay of the median person in Medicare that year. So that's it. There are no other treatments, no bus fare, no nothing. So that is something that is the reason that healthcare is often called its number 2 cause of bankruptcy. That's the reason we have weird structures around Part D and these bronze and silver plans and the exchanges, because the costs are so high that the coinsurance is a natural consequence of it. So healthcare is, you can argue that we should only have negative rights by the government, which means why a reason healthcare isn't a right, but frankly, it's not a right because we don't act like it's a right, and it's clearly a privilege of the few.
Can you discuss orphan drugs and explain to the audience how compensation to the pharmaceutical companies on orphan drugs works?
Without talking about the details, there's actually quite a few categories of compounds, drugs and devices that deserve special, or that earn special treatment. The same is true for providers. You build hospitals in certain places, you get more payment. You as a doctor practice in different payments. So there's a whole skein of different kinds of incentive structures, all probably well-meaning, but orphan drugs have both an FDA and a reimbursement kind of safe harbor, where if for argument's sake, doesn't take as much data necessarily, doesn't take the same sort of population size, doesn't have to pass the same standard of safety and efficacy necessarily. Safety usually, yes, but efficacy to get approved by the FDA. And that well-meaning construct has benefited people, has benefited patients, but it's also been taken to an extreme. So we have compounds that are for metabolic deficiencies, which are owned by companies that have multi-billion-dollar market caps and things like that, because the price is sort of no limit. We have a drug out there that's $500,000 a year, for example, in that area.
And how many people does that help?
That's a great question. I don't have the number off the top of my head. It's a small number. It actually fits as an orphan disease, but we're seeing a trend towards segmentation, what we used to think of as large populations, into sizes small enough to meet the orphan categories. So we're subsegmenting cancer, that's a good thing, into different genomic alterations within organ types, that's again a good thing, but it's being used to some extent as a path for more easy approval. And that may or may not be good. We'll have to see how it sort of shakes out.
Jared, as an economist, we've had two views so far on costs, structures. Do you have any view from the science slash
not
art
really.
of economy?
No. Sure. A couple of things come to mind vis-a-vis what we've heard so far that I think are interesting, and let's see if you agree. First of all, listening to Sue talk about some of the areas of investment and savings, I was thinking about where those cost savings, who they redound to, who they help and who they hurt. So to what extent is a physician incented in our current system to engage in practices like electronic records in such a way that could perhaps save costs for patients, but lower their income? So I'm interested in hearing you speak about some of the poorly aligned incentives there. And then vis-a-vis the very important information that was just shared by us from Peter, would you go to slide 22, please? Everything you just heard about drug costs is absolutely the case, and that was just one area. You'd be hard pressed to find any area of illness that didn't have that characteristic. Yet, as is well known, widely accepted, I don't think this is at all controversial to members of the panel, the rate at which healthcare spending has increased in recent years has slowed very markedly in ways that are critically important for the economy as a whole, because we're talking about 17–18% of GDP, and for the fiscal budget. Because for all the noise we make about the discretionary spending and aspects of the budget, which is where Congress has generally cut, everyone knows the real pressures in the out years come from increases in healthcare spending matched with demographics. So if, in fact, we've really made some lasting progress against this seemingly inexorable increase in healthcare spending, that's very, very important, creating more fiscal oxygen and, by the way, in my view, underscoring some of what you've heard and what you will hear from the panel in terms of the ways in which delivery changes have helped bend that curve. But there are risks. And so this slide shows probably the most important single aggregate measure of healthcare spending and its impact on the economy, the excess cost burden, which is the number of percentage points that healthcare spending is rising above GDP. And every time that happens, the share of the economy, just by arithmetic, that we devote to healthcare goes up. Well, I remember back in the mid-90s when shift to managed care really took that trend down, and a lot of people were celebrating, myself as well. By the way, the impact on the economy was dramatic. Job growth accelerated in ways we really haven't seen since, in no small part due to the deceleration in costs faced by employers on the healthcare side. But as you can see, for all the woohoo, there was a big whoops following that. That clearly didn't last at all, and I suspect members of the audience know that that shift to PPOs and HMOs turned out to be an intercept shift, not a slope shift. If you go to the current, so the question now is, are we in a woohoo moment or a whoops moment? And there is some recent data out of various sources suggesting that once again prices are accelerating, but they're not accelerating as much as they're not accelerating to the extent that we'll get. The thinking is that we haven't made some lasting gains, and I'll stop here. and tie it back to what we're talking about here, the etiology, the origin of those gains seems to come from two factors. One is the recession, is a cyclical component. As the recession ends, the demand for healthcare grows. But a lot of this stuff is inelastically demanded, especially in Medicare, and we've seen cost savings in Medicare. The second seems to be with delivery changes. And I'm sure we'll talk more about that as the panel goes on. But I don't think we can effectively maintain the gains that we've made on the excess cost burden without digging more deeply into the kinds of ideas we've begun to talk about.
So for anybody on the panel, and as an economist, you probably have particular interest in this, when something becomes, let's say, less invasive, it seems that more of it is done. So at one time, gallbladder surgery was a major surgery, and a certain amount was done. And then someone figured out how to do it laparoscopically. And they said, this is terrific because now it's going to be less expensive. The result, of course, is more gallbladders were done. And I think that happens with many procedures. Now you have minimum invasive surgery, and it just means that more of it is done. So even though the time is less, maybe the anesthesia cost is less because of shorter period of time in the emergency in the operating room, it seems overall the cost pressures continue to increase. And I was wondering if anybody had any comments on that.
I mean, I think that one of the things, at least where I go with that, is the idea, you hear it a lot, and the president himself talks about this, the idea that we definitely have a system that incentivizes quantity over quality. And I think that the way to think about what you said is a tiny bit of arithmetic. For me, the key way to think about this is to think of price times quantity, which is, of course, the aggregate of what we consume in healthcare. So price times quantity divided by quality. And every one of those factors will impinge on the future here. Now, if by dint of lowering the price you increase the quantity, that doesn't help you. If you increase the quality, that does help you. And so I think in the case of what you're suggesting, where I see some delivery advances going, particularly having to do with information from consumers, with bundling, with getting away from payments for fee-for-service, with more salaried kinds of things, with medical homes, all of these delivery mechanisms, to my view, kind of work against the incentives in your scenario, because those are incentives that have bedeviled the system heretofore.
Can I just ask a question? How do you define quality as your denominator? And what is the universal healthcare quality metric? Because that seems to be one of the conundrums in healthcare. There isn't really.
So I'll answer that, because I was going to ask that.
Okay.
So in
I'd like to change the rules.
Africa, it's sometimes equivalent to mortality.
I'm sorry?
In Africa, sub-Saharan Africa, it's mortality. If you live, then you have good quality. In Europe, it could be morbidity. If you don't have too many complications, you have good quality. In Canada, I've heard it be said that it's motility, if you can walk around afterwards. And in the United States, particularly in California, it's how many threads in your hospital gown do you have? Do you have valet parking? That's quality,
right.
Particularly in Beverly Hills, maybe Manhattan. And I've also heard it be called the James Brown effect in California. Everybody just wants to feel good. So that's the definition of quality. So, but I think that's a great question, because I don't think anybody has standardized what quality is.
I think that's true, if I can jump in. And the issue, I think that was if you will, a schematic of value, right? That's the new term in healthcare. It's one that I think we're all worried about. We'll start getting stuck on things without any concrete definition. But we have had such a hard time just wrestling the P's and the Q's to the ground on this, that the move towards value, although it makes every sense in the world from a purchaser standpoint, from an improving health standpoint, from a basic economic standpoint, it will be plagued by these challenges. And I get the implication, the sort of lightweight metrics that you're talking about, and that I actually will put forward a real metric that I think is extremely lightweight, which is wait times. Right, and you're absolutely right that this is the question, and I work at a hospital, we measure wait times, and this is something that hospitals and systems are being measured against, and it's really sort of a dumb way of thinking about how to use an extremely expensive resource is for surge capacity, because that's essentially what dictates wait times. Is lines get longer, there's more people waiting, that's how the math works. So we need to move a long ways towards understanding value, and I think the issue is, and Castlight's a great example, right, of transparency around pricing, and there is a real effort with the STAR system and things like that to get something about quality in there, right? Like I could go to this orthopedist or that orthopedist, but we do have this other tension, and just to further muddy the waters, which is that as you start to post things like pricing and crude measures of value, you can have commoditization before you're ready. Right? We're pretty sophisticated on drugs, brand versus generic. We're kind of sophisticated in devices, certainly on disposables. But when we get to the delivery of health care, commoditizing doctors' services, surgical skill, and things like that, that's going to be really hard. Just the math around that, again, measuring, for example, the quality of surgical care for a particular procedure requires denominators we don't have for many doctors. Not because we don't have the data, it's that they don't do enough of it.
Just a very quick point, because there's people we haven't heard from yet. So very quickly, I think that's true, but it's very gnarly and detailed and nuanced, and that's where ultimately I'm sure we have to go. But isn't there a lot of low-hanging fruit in the quality world? Isn't it widely understood that because of the incentives in the system, for example, we do tons of back surgeries that are just wasteful, induced pregnancies. I think there's heart treatments that I think are widely understood to be ineffective, inefficient, and don't lead to better health outcomes. So at least at the low-hanging fruit level, I think the identifying quality maybe isn't as hard as all that.
Well, that's a perfect transition. We're going to talk about academic medical centers. Larry, is an academic medical center an anachronism in today's world? You are charged with training our future doctors, and you're charged with doing research, and yet the payers do not want to pay for that. So how in today's world do you exist? And you are the ones that are measuring quality and doing a lot of the research that will solve some of the problems that we're talking about today. So maybe you can answer that.
Sure. So I'll start out by saying that I think we're better at innovation than implementation, and it gets to some of these points. So one of the things we're trying to do now is to actually innovate around implementation. And I want to restate some of the basic statistics that you've seen out here. Healthcare expenditures in the US are $3 trillion. My calculator doesn't go out that far. So as a scientist, I can convert this into scientific notation. One comparison for me is the Human Genome Project. Takes on the human genome, which is 3 billion bases, small by comparison to healthcare expenditures. So what we're trying to think about is, how do we bend this healthcare cost curve? Because any effect, even as small, will provide a huge amount of resources for the businesses and the finances of the United States. So one of the projects we've been working on is the convergence of technology for chronic disease management with behavioral economics, and then ultimately to work in the policy arena so that we can align the incentives. So I'll give you a couple of examples. Most of our disease growth now is chronic disease. Obesity, diabetes, high blood pressure, CPAP treatment for sleep apnea. You can go on and on. And fortunately, there are a lot of tools that we can use in the technology sector that can measure these events outside the hospital. So most patients will see a doctor or a nurse once every 4 to 6 months. That's 1 hour. They're back in the home environment for 5,000. So what are we doing with those 5,000 hours? We need to make them productive to manage these chronic diseases. So the linkage is between the tools to monitor, did you take your pill or not? Did you measure your blood pressure and what was it? Did you measure your glucose and what was that? All of that information can be sent into databases now and aggregated very inexpensively. So the really crucial question is, how do you incentivize the patient, together with low-cost health assistance, to be compliant with their medications? Now, believe it or not, most patients who have had a heart attack adhere to their drugs to lower cholesterol at a rate of around 50%. It doesn't make any sense, because most chronic diseases don't hurt until you come back in with your next heart attack or you've had a stroke as a complication of diabetes. So it's an essential question to develop strategies to change healthcare behavior. So the group at Penn, an academic medical center, has a collaboration between the doctors, the Wharton School, where they have behavioral economists, and the biomedical and ethics groups, where they're trying to experiment with lotteries, where patients can receive a lottery that can either be donated to charity or perhaps go into their bank account. And the goal is not to pay the patients for managing their own disease, it's to find out which maneuvers incentivize the behaviors. So how often should you interact with them? How big should the effect be? Should the lottery go to a family member instead of the patient, someone who can influence their behavior? So those kinds of experiments, I think, are the kinds of activities that academic medical centers can do that will provide a proof of principle that might be expanded more broadly.
Are you in jeopardy having a community hospital compete against you because an Aetna or United, although going to an academic medical center is terrific for tertiary care, but a hernia, gallbladder, you have to charge significantly more to maintain fiscal integrity. How do you work with that?
Well, most academic medical centers are now trying to develop a network, either formally or informally, so that patients can be best directed to the right level of care. So for primary care and relatively straightforward medical programs, you want to be in the lowest cost, easiest to access environment. But when you're coming in for your second radiation therapy or for reconstruction of a hip transplant that needs to be repaired, at that point you may need to go into a higher cost environment with a surgeon who's got a lot of experience, minimal variation in outcomes, a lot of data about what those outcomes look like. And I think the transparency that we've heard about can be very helpful with that to help direct not only the patients who rarely have the sophistication to maneuver through the healthcare system, but rather their healthcare providers to try to direct them to the right level of care.
So when a run-of-the-mill surgery is needed, do you acquire local hospitals that are lower cost? And
Yes,
do you think
no,
that's...
and I think through Castlight and similar activities, there'll be transparency about what the costs are in these different environments, as well as what some of the outcomes are. And for many patients, the access will be easier in those environments because the wait time to get in will be more rapid, and they can make a decision about, do I want to go to the sooner appointment where I can get equivalent care, or wait to go into the tertiary environment, which is by and large not the right place for relatively straightforward care.
Sue, last but not least, technology is enabling new models in healthcare, and I know you're big on partnerships. So how does GE and how do you look at the new technologies, the new partnerships?
So the world of SMAC technologies, really looking at software and mobile and analytics and cloud, really have converged. And those have become absolutely necessary in this new ecosystem. We fundamentally believe that. Annie talked a little bit about what, in fact, the investing thesis are around those. In terms of community, in terms of partnerships, we don't fundamentally believe that anyone can do this by themselves. There's just not a possibility. But what we're seeing, and GE has tried to do this, is the following, which is communities can actually self-serve. And when you think about the employer role in this, and I'm going to weave this together in a second, it goes like this. Employers essentially pay for almost 80% of the healthcare bill here in the US, right? So Jeff Immelt, our chairman and CEO, back in 2010, when all of this was starting to happen around Obamacare, if you'd like, was saying, well, why do we as employers have to wait for anybody to tell us how to go about doing this? And why don't we figure out how to work with local communities to see if we can in fact affect change? And so what he invited was to go to Cincinnati, for example, where we have a big footprint, and invited other large self-insured employers and said, in essence, if the payers are in the room, and it's not really the insurance companies, right? It's the large self-insured employers or those that in fact are paying the insurance companies to actually manage risk. When you start to think about that, others will come. So in fact, what ended up happening, our providers came to the table, insurance companies came to the table, and this was the start of what we're calling our Healthy Cities program, but in essence, bringing together a self-assembly, if you like, articulating certain goals that in fact the community wants to embrace, and then figuring out how to sustain that. And what's happened, which was, we weren't quite expecting it, because this is hard going, as we know, is that Cincinnati did self-assemble, and they have their health collaborative group that in fact continues to move this on. And there was, lo and behold, the following things that ended up occurring. Pricing transparency due to connectivity that was agreed to amongst the 19 different hospital systems and other provider groups. The ability to really, over time, put out the what the true cost is for certain various provider groups. Not all of them have done it yet, but they're working towards that. In addition to that, they've adopted PCMHs, right, patient-centered medical homes, and that continuum of care model, which has, just to give you a sense, there was almost 0 of them in Cincinnati, and now there's about 300 or 400 of them, of which GE helped to get about 200 of them in place. And what that's done in terms of healthcare services delivery is that instead of having so many different specialists or different medical providers that really are disparate, and you guys have experienced this yourselves, right? You don't really, you've got to figure out for yourself exactly what's going on in your medical care. If you have one actually trying to do that for you, it really helps in terms of the kind of care you receive. Incorporated into all of this was really the notion of incorporating a lot of these technologies to bear and the ability for folks to get educated in that particular realm. And it has really helped. Some of the initial reports that we're getting in 2013, for example, there was $200 million in savings just in admissions and readmissions alone in a few of the hospitals. And RAND is working with us to really dig into some of the real data overall in the city of Cincinnati. But it gives you a little bit of a sense where community can actually impact how this works. And you don't have to wait for major policy issues to actually occur. You can self-assemble. And it might sound like motherhood and apple pie, but we're doing this now in Erie, Pennsylvania, and also in Louisville, Kentucky. Hard going. We've just launched in Houston, hard going. But we've been amazed now in Erie and in Louisville how, in fact, the community wants to use this to become, if you like, one of the competitive cities to live in America. Because now healthcare is becoming such a competitive issue for the U.S. that in fact they want to be seen as a place to live and be able to be featured as a place to live. And Cincinnati has certainly been working at that towards that too.
Let me just, if you would put up slide 23, just to have a picture of what Sue was just talking about. I mean, this is a very striking trend in diminished readmissions relative to a pretty long-term average there. Again, you could argue, a lot of people look at these recent trends in cost savings and say, well, that must have something to do with the recession. It's hard to see to me why reduced readmissions would be obviously cyclical. I think it's probably more a function of what Sue was just talking about.
Well, I think there's also a direct incentive or penalty for readmission.
No, I think that's what it is.
It's what it is.
That's what's driving it.
That's what's driving it.
Well, I want to make Jared feel a lot more comfortable in his skin going forward, because I think this trend is going to continue. Yeah. I think it's all the things that have just been said, but there's been a fundamental change in the profession of medicine. And it really began with the reports out of the Institute of Medicine on crossing the healthcare quality chasm and to err as human. The things that we measure now are in the hundreds. We look at our cardiac surgeons and we know how long their patients are in the hospital, how many complications they've had, and when there's variation, there's feedback to minimize that. Every operating room now has a protocol before you start the procedure. Is it standard of care? What's the role of everyone? So we see length of stay dropping pretty much across the board. Sometimes it's a new minimally invasive procedure. You save a lot of costs that way, even though the quantity goes up. But I think the profession of medicine is now very focused on reducing unnecessary errors, or reducing errors, and reducing unnecessary variation in care. And the incentives are beginning to press that even more. So one of the things that we see happening in the Philadelphia market are experiments with some of the payers, like you described, Sue,
Right.
where if a patient is discharged from the hospital and readmitted 3 or 4 years ago, the hospital receives reimbursement for the new admission, actually at a very high level. And it's not good for the payer either. So there's an incentive on both sides to prevent that readmission. And so we're starting to share the expense and share the gains with the payers so that now services can be provided to manage patients outside the hospital. It's win-win.
Can I just
That's-
comment on that
okay.
for a second? Because
Absolutely.
one of the things that is starting to happen here, and you refer to it as the medical profession, but medicine's becoming an industry, right? And business. And when you start to think about that from a business perspective, why can't you treat health as such? All right, I know it's personal, and I know it's emotional, but if you think about it, and this was sort of an awakening for me, and maybe many of you have come to this many moons ago, but at GE, one of the things, we have a $3 billion healthcare bill every year, and it was growing at double-digit rates. That is not sustainable, right? And we all know the story of GM versus Toyota and how they went about the healthcare benefits and other benefits per employee and what happened over time. We've climbed out of that, but it took a long time. So for the sake of national competitiveness, when you look at the medical industry and how it's really becoming a business, the metrics become important. The way you go about treating those metrics become important. The business models associated to it all of a sudden become like other industries. So you're going to be applying all these various business models that we see in retail and putting them into medicine all of a sudden, because the consumer is going to feel it in our pockets. And because we're going to feel it in our pockets, we have to be able to make those decisions. So we're going to need that support system to allow us to understand what kind of medical decisions we're making. And so more and more, this whole notion of the digitization of medicine, the industrialization of medicine, the retailization of medicine, it's the business of medicine. And it's becoming one where, like it or not, it's the reality.
So for those in the hospital industry, there are a few things that will lower readmissions. One, a 400-bed hospital has more readmissions than a smaller hospital. Patients that have English as a second language have more readmissions, things that are common sense. And when a primary care physician is separate from the hospital and the patient feels the primary care doctor is at the hospital, there are more readmissions. So something as simple as that. Most of the stuff is simple blocking and tackling. It's not particularly complicated, but the incentives are cross purposes in healthcare,
right,
as you pointed out. So much of this is culture. A few years ago, they measured Dade County, Florida, and on average, 21 days of the last month in a person's life was in the ICU. In Minnesota and San Francisco, it was 3 days. So if you go to Dade County, Florida, and you could provide a new process, and you might be able to lower it from 21 days down to 16 days. And they would say, isn't this terrific? Look how well we've done. But it's sort of like the fruit is so low-hanging, it's actually on the floor, that a cost, an MRI cost, does anybody have any feeling the difference between MRIs and at the most expensive level and the least expensive level? And
It can range.
Cost 20-fold.
Yeah.
20-fold in some markets.
Okay, 20-fold. So someone could say, I did this research and I lowered it 10%. So now it's only 18-fold. And there's a lot of clapping, and there's a lot of collaboration between hospitals and inefficient medical groups and health plans. And people usually blame the health plans, but really it's the employer, as you pointed out. They're the ones that are being impacted.
Up in arms.
Up in arms, up in arms. So on one hand, I think that there's going to be more attention and costs are going to be lower. Number one, we had a recession. Number two, it's so expensive. Number three, the health plans are responding by holding the patient, the member, more responsible. And when they have to pay their own nickel, they're not going to buy as much. That's on one hand. On the other hand, Annie, you're helping with innovation, and there's going to be more drugs, more everything in medicine, and it's going to help quality and it's going to help outcomes, but not everybody, in my view, not everybody is going to be able to afford it. So currently, I'm going to ask about Obamacare. Currently, people are subsidized, and so that's going to help for another couple years, but what's going to happen after that subsidy disappears? And I'll open it up to anybody that wants to comment on it.
Well, first of all, I'm not sure what you mean. I mean, the subsidized premiums are part of Obamacare that are going to be there as long as there's Obamacare. So, are you talking about the Medicaid expansion? I'm not sure what you mean.
Well, there are two parts to it, right? I mean, one is, are the states going to be subsidized? And the subsidization of the states' Medicaid programs is going down.
Well,
but I think individual subsidies will remain.
Well, yes, and when they go down, the state subsidies go down to from 100% to 90%. So, I mean, it is going down, but it's. Still think it's a good deal for the states, but I'm not a governor.
Some states
and
disagree.
I'm not a Republican governor.
How many states embraced it?
Let me see. Is it 27?
27, I think it is, yeah.
Is that right? Something like that. And then, it ain't over.
It's over 50%.
Well, that's Alexander Hamilton versus Jefferson. I mean,
One commentary, instead of Affordability Act, you might have named it Accessibility Act. Because when you think about what it really addressed, and there's a lot of questions to this, and I won't comment on all of the economics associated to it, but was really about being able to get much more accessible care for everyone, right?
And are physicians accepting the compensation that they're receiving, or are they saying, we will not see these patients?
Well, that's a whole different question, because physicians, frankly, now as we're learning, and in fact by 2020, aren't they talking about 80% of those physicians will be hospital employed? And so the kind of compensation now is not down to the physician level, it's down to an entity level. And you're starting to look at how they're in fact making those decisions and being able to have the, if you'd like, systems to be able to decide whether to take them on or not.
And why are hospitals, not why are hospitals embracing physicians, but why are physicians embracing hospitals?
Because they can't compete.
Right.
Because
so there's not enough revenue in the system for them to be independent.
Well,
I'm not sure that.
Yeah, I think there's plenty of revenue in the system.
I don't think that explains the trends. I think there's several things. First of all, if you look at there's a huge secular effect, right? So newer minted doctors have a proclivity for being in an employer-based model or in a staff model. So we're seeing a huge migration towards a sort of, I want to work for a big hospital, I want to be part of a system, I don't want to take weekend call and hang up my shingle. We also have this perversity in the system around drug reimbursement, this 340B drug discount program, which the Affordable Care Act extended to numerous hospitals. I think we're at 1,500 hospitals now that have access to these drug discounts. That creates an incentive for them to buy practices or otherwise affiliate. There's a couple of structures that are legal. And then they can move drugs, either outpatient drugs through contract pharmacies, like Walgreens is the one that's gotten the most headlines, or physician-administered drugs, like the drugs I tend to be interested in, which are cancer drugs and things like that. And when they move them through these doctors' offices, they capture this huge difference between reimbursement rates from Medicare or insurance companies like United and what they acquire, which are mandatory discounts of 40, 50%. So they are buying up these practices left and right, essentially as distribution channels. And regulators are nowhere in sight worried about this. But that is causing unbelievable market perturbations, far more than doctors not being able to compete. If we look at the Medicare data that was released a couple weeks ago, There's doctors who are doing just fine.
That's Brooklyn.
There are several reasons why.
Few of them were in Florida, too.
Several reasons why physicians want to come under these larger umbrellas, and we've touched on a few of them. One is in rolling out electronic health records across the system. This is a very expensive undertaking for an individual practice. And most physicians in the US are still in solo practice or very small groups. And to invest in the capital, the training can be $75,000, $150,000 per practice. And if health systems can roll these out, there's that incentive to come under. It does help not to have to run the business of medicine at the same time that you're practicing. So if a large system of care can take care of that part, negotiate with the payers, take on the billing. So there are multiple forces bringing people in. What I wanted to underscore is I think it's a healthy thing for healthcare because we can put teams of people around the problems of patients much more readily when you don't have individual doctors all trying to take care of different parts. So if you've got an infectious disease specialist, a pulmonary specialist, anesthesiologist, surgeon, all working in different business units, now they can come in together and you can really focus on how to deliver whatever is needed most effectively, and the doctors become salaried. And so there isn't this independent driver to increase the number of procedures as part of the way they're trying to run their businesses. So I think it's a healthy trend.
I have a couple of observations / questions for fellow panelists on some points that just came up. So you make the point, Larry, about the individual doctor in their office. I mean, I actually have a dentist who I don't think has a computer system. I mean, you talk to them and they write down your next appointment on a file card. And I think while the hospitals seem to be engaging in some of the network externalities that you really benefit from that are essential to moving forward, as Annie and others have mentioned, I worry about the individual physicians and the small practices. I don't even really understand what incentive they have to do that other than maybe a patient grouses, gee, I'd like to be able to do this by email instead of you give me a file card. So what is there something anyone can think of that would help crack that nut? Interestingly, by the way, in the Recovery Act of all places, remember the Recovery Act, the Stimulus Act, there was a $50 billion program to incentivize electronic records, but I believe it was largely on the hospital side. I don't know that it reached down.
No, it went to the practices too.
Oh, okay. So
they got $44,000 a year.
So I guess part of my question is there a role for government in helping to crack this nut? I don't know.
Well, I think
and just secondly, so look, the prescription on the drug piece, what are your favorite solutions for this problem? Because it does seem to be when I look at the delivery mechanism change that we've been talking about, the bundling, the incentives to physicians, readmissions, I can totally get why those incentives work. I haven't been able to figure out what helps in your area. So I wonder if you have thoughts about that.
Sure. I mean, I think it's a hard problem to solve, which means I'll have a job for a while, and which is, of course, my incentive. I mean, I think bundling or shifting risk to the prescribing physician, if you do it right, creates an incentive for the doctor or prescribing entity to seek lower cost inputs, right, in the classic sense. So if we had enough risk shift to people who had credibility in terms of the practice of medicine, rather than insurance companies, which have always been sort of separated from that pretty effectively through, PR and stuff. But if we had docs standing up and saying, okay, I can do this thing that's lower cost, it does filter back up to the supply chain, right? And I've argued for a while that these prices are largely a fiction, and most of these companies can sell into other countries for 50% discounts, 60% discounts, and they're doing just fine. They're obviously making money or they wouldn't do it, right? I mean, except for a few rare things like Africa or Egypt or something like that, right? So if we could, that bundling works for this if we have quality controls in place. So I think that's one piece of it. On this doc thing being swallowed up by hospitals, we got to be cautious. I'm looking at the National Health Expenditure slide here in front of me. I guess it's not up there, but it doesn't matter. It's going up in case you haven't seen the slide. Hospitals eke out more reimbursement per unit of service than doctors do. And I work for a hospital, so full disclosure here. On the drug side, the average reimbursement for a chemotherapy drug in a hospital is 4 to 5 times from private insurers as what it is from the doc office. Never Medicare fixes its rates, right? So each time a doc practice gets swallowed up, those unit costs go up many-fold, and that filters right back to insurers, that filters right back to employers, that filters right back to me who pays premiums. And so you would have to show me that value by your equation goes up 5 times to normalize that numerator and denominator. That's not happening. And the truth is that many of these doctor practices being swallowed up are just sort of doing business as transformations. They're paper transformations. The doc doesn't move, the patient panel doesn't change. They get a new logo. They do get the EMR, absolutely. No one's shown that either saves costs or improves quality, but so be it. And they're just business as usual, and then they pass through these unbelievably higher reimbursement rates.
Most docs find electronic medical records makes them much less efficient. They can see fewer patients a day. They're not used to it. And we have, I think, 2,000 licenses, and we will give it to the doctors. They don't want it.
I had a full head of hair before I got an EMR.
There you go.
So I think
There's
another
a learning curve, let's put it that way. I think there's another program. I mean, when you think about the HITECH Act actually inspired doctors moving into employment model. There's Affordable Care Act, but we haven't even talked about what's going on with the dual eligibles in terms of the state waiver program. And so the dual eligibles are those that are the sickest of the sick. It's $300 billion of expenditures in the United States. And so they receive Medicare and Medicaid. And they've been incredibly mismanaged because there is no caregiver. The doctor doesn't even know whether he's going to be reimbursed by Medicaid or Medicare. There's nobody watching these patients. So the Obama administration has created these waiver programs that states have applied for. Illinois, Florida was the first. Hawaii, California, it's gone across the country. So that Medicaid HMOs are mostly winning these bids to manage these patients, sort of be that integrated system for them. And I think there's enormous opportunity and savings there, as well as much better care for these people. So I think that's actually, we talk about inflation curve going down, I think that's actually another area that's going to be less spending, not more in the future.
We have a few more minutes. Would each panelist sort of summarize what they would like the audience to get out of this?
Well, I think we need to think about healthcare as a business and really start applying, just like in any other industry, the disciplines of business in a way that makes it much more competitive, much more open, and one that does not have as many protections as currently exists in the healthcare ecosystem. And I mean, I could go on for a long time about this, but I'll leave it at that.
Yeah, I think just reinforcing in $800 billion of waste, we can improve care and spend a lot less. I think we just got to keep putting pressure on the system because the stakeholders have not really transformed themselves for a very long time, and you've got to keep pressure. I mean, when was the last time you heard of your local hospital going out of business? It doesn't happen. I actually don't, other than academic medical centers, I'm not a big believer in not-for-profit hospitals. They behave like for-profits. I spend a lot of time with these people, and yet they're not paying taxes. So I think keep the pressure on. I think it's been the most exciting time in terms of an investor in healthcare. Tremendous innovation, lots of great actually technologists and innovators coming in as entrepreneurs in the area. So it's fun.
So disruptive innovation is happening. It's happening in the technology sector. Our ability to do minimally invasive surgery, to target drugs for particular mutations in cancer so that you minimize side effects is there. But the consequence of that is going to be more people wanting these things. So the volume will be going up. So I think we have to focus very sharply on implementation so that we do it cost effectively, and we have to align the incentives. With tweaks of the incentives in the reimbursement system, magic can happen. And it's the most challenging part because you have to go from the current state where everyone is driving towards the current incentives, whether it's to admit people to the hospital or to do more procedures. But if we shift it, the system will change. And the workforce is coming along very quickly. While it may be true that some physicians are less efficient on new electronic health records, We're training a lot of people in medical school today who will be very comfortable with that. You take it forward another 10 years, and I think we'll have a lot of data to work with.
So slide 20 shows that over the next 10 years, according to the Congressional Budget Office, the savings from the kinds of advances we've talked about today, much from the delivery side, some of which may be cyclically related to the recession, reduced spending projections over the next decade by 1.2 trillion, so you can keep your calculator. And so the point is, the punchline for me is that taking away these ideas, running with them, trying to figure out what works, what doesn't, has the potential to create tremendous fiscal oxygen and economic benefits.
That's great. So I guess the caveat for me, or the point I would have liked to have made earlier, so I'll make it now, is that when I look at these solutions, and I think I share the optimism of everyone else on this panel, we have to be very cautious about trying to change consumer behavior through economic or financial incentives. And the reason is that our experience, and it's decades and decades, including randomized trials, is that when we start in doing things like making patients cost share, they do exactly what we don't desire them to do, which is not improve their health. Women stop taking tamoxifen, the generic drug that's prevented more cancer deaths than any other drug we have, and they stop taking it with minimal copays. They stop taking Gleevec. Women stop having mammograms when we added $10 copay in some Medicare managed care plans, about 12 to 15% of women. So we cannot modulate our utilization through coinsurance without losing the primary purpose of healthcare, which is improving health.
Great summary from everyone. Thank you very much. It was my pleasure to moderate.